I'm a hepatologist who 20 years ago got interested in obesity, which I'm not, and metabolic diseases. So I'm coming at this from the back end, if you will. I'm going to talk today, and I was asked to talk about weight reduction, which is something I think about a lot for the many complications of obesity, but in particular, how weight reduction may have a unique role to play in the pre-transplant patient who's becoming transplanted for NAFLD. So if you look at obesity as a problem, and this is the U.S., so for those of you who are not from the U.S., just bear with us, but other countries are catching up or have passed us. Countries such as New Zealand is equal to us, and the whole Middle East is past us, and South Africa has passed us, and Canada is equal to us, and much of Europe, and particularly Eastern Europe, is equal to us. So this slide applies to them as well. If all of the white on this slide represents the adult population in the United States, then the number of people with Parkinson's disease and HIV/AIDS are shown in the orange and purple dots. The number of people who have the disease of obesity is going to be shown on the next slide, and that includes people who are overweight, because overweight is the same disease. It's just a milder form. I like to call it pre-obesity to use the diabetes nomenclature. And that's what that looks like, obesity disease. If you look only at a BMI over 30, which is half of that group, that's that size. And if you look at people who have type 2 diabetes, it's that size. And I'm not going to show you all of NASH because there's a lot of, well, not a lot, a little bit of debate about that, but I'm going to show you, oh, here's all of NAFLD, so that's even bigger than diabetes, that shows that. And then if you look at NASH per se, you start to get some more accurate data. And you can see that still, though, we're looking at a disease whose prevalence is substantially higher than other diseases that we treat, and I'm talking about NASH now, I'm not talking about steatosis, bland steatosis. If you look at cirrhosis, it's the size of the dot shown here now, and so just that population is what is setting the clock into motion. If you watch CNN, you'll see that it's, now it's T plus 6 days from our election, usually it's T minus. It's T minus 3.5 years until UNOS announces that we expect UNOS to announce that fatty liver disease is the #1 cause of transplantation, maybe a little earlier than that. We'll see how that goes. But this is the epidemiology of what we're looking at. And so that just that cirrhosis dot is really what we're talking about. Not all of that cirrhosis is going to transplantation, but it's a pretty big group of people. Parkinson's disease is about 1.7 million, 1.8 million. HIV/AIDS is about 1 million. And so you can see the cirrhosis is about 1 million as well. Now, if you look at obesity from the flip side, you look at obesity, which is clearly associated with fatty liver disease, we could think of the medical complications, and we have a paper that we just presented last week at the obesity meetings, trying to look carefully through a structured evaluation of the literature. We looked at 24,000 papers, and we looked at the comorbidities, and there are too many to name, but they come into the metabolic ones like diabetes, fatty liver disease, gallstones, and the like. Structural ones have to do with shapes, center of gravity, pressure relationships. Inflammatory ones, we now know that obesity is as an inflammatory diathesis, and autoimmune diseases are more common. Degenerative take time to develop. Neoplastic include all of the major screenable diseases, 5 or 6 or 7 GI and hepatobiliary cancers, including cholangiocarcinoma and hepatocellular carcinoma. And then the psychological ones, primarily depression and anxiety disorders. When you add them all together, there are 236 of them. That's what we reported. It'll probably go up by the time the paper comes out. But you can see that this burden of associated disease affects anybody who has any other associated disease, so therefore people with fatty liver disease at any stage may be beset by any of these other 235 diseases. And so we have to think about that as we move forward. I'm going to talk about the big ones, the ones that have been published on, but suffice it to say, the burden of disease with obesity is enormous, and the Global Burden of Disease Project out of the University of Washington, which categorized the global burden of all disease, when you compare these data with those data, you would say that about 35 to 38% of all disease is associated with obesity, at least in the US. Now, obesity-related risks of transplantation for NASH particular include renal dysfunction, which is probably the complication that's most often talked about, coronary disease, which of course is more common and is associated, as we learned at this meeting in both directions, coronary disease seeming to promote NASH and NASH to promote coronary disease. I'm not really sure how strong those data are in terms of causation, but there's a clear correlation. Type 2 diabetes, of course, decreased graft survival, increased blood transfusion requirements after transplantation, increased length of ICU stay, increased mortality rate, and if that's not enough, in the new liver, there's almost a 33% chance of recurrent NAFLD. So that's what we've got. Now, it's interesting, and it will be interesting to learn whether that recurrent NAFLD is going to have the same progression when we look at big studies over a long period of time. How much do the genetics of the transplanted liver influence that? But that's a subject for a different day. Now, in terms of NASH patients, weight loss can be considered in two ways. First, one is to overall, weight loss can improve the current status and the progression of the disease. That's been demonstrated most clearly with bariatric surgery, which is not the subject of my talk, will be the next talk. But that is a method of treatment chronically. And so you can improve the steatosis very rapidly with even modest weight loss, although we have no good evidence that such weight loss will prevent or slow the progression to NASH. In fact, even the issue of whether it's a two-hit model or a one-hit model with a predisposition is still not 100% settled. You can improve inflammation and fibrosis, but that's a slow process that requires substantial and persistent weight loss, which is much harder to achieve. So getting rid of steatosis is easy by comparison, and it doesn't take as much time. And so the most reliable approach has been with bariatric surgery. Bariatric surgery may actually have weight loss independent effects on steatohepatitis. There are no good human data on that yet, but there are some now animal models which have progressive fatty liver disease into hepatitis and cirrhosis, that and maybe even in some cases to hepatocellular carcinoma or its equivalent in mice. And so there may be weight loss independent effects. And of course, anti-obesity medications is the other way to approach this most dramatically, and I'll talk about that, but that's not very well studied in NAFL or NASH at all. Now, in pre-transplant NASH patients in particular, well, since most patients with NAFL have obesity, and since obesity is associated with all these other diseases that could make the whole process of transplantation and the after effects so much more problematic, it would be nice to get the weight down. But in this case, we want to improve the outcomes of liver transplantation. And in some people's minds, you don't have to do it by long-term weight loss. If you can improve some of the outcomes by short-term weight loss. And I think it's very important to distinguish long-term weight loss, which is hard, from short-term weight loss, which is relatively easier. So obesity treatment, the way we do it, and I'm going to talk to you about exactly how we do it in a minute, is we use a stepwise approach. This should be obvious to any chronic disease. That's how we do any chronic disease. For some reason, people who treat obesity in any venue forget their basic medical principles, which is if you're treating hypertension, you start with a regular drug that I call it an anchor drug, a commonly used drug, or diabetes or dyslipidemia, and then you add a drug or substitute a drug or add another drug or a third drug or a fourth drug, and eventually you refer to a specialist if it's complicated enough. We don't typically do that with obesity. We typically say lose weight, exercise more, eat less, go home, and that doesn't work. Now, transplant patients, particularly those who are far along and have a higher MELD score or farther along on their journey, probably require accelerated escalation of therapies from lifestyle to drugs, maybe to surgery. We'll come back to that in a second. If you're going to use bariatric surgery before transplant surgery, however, you got to get in early, because although some people are using transplant surgery and bariatric surgery in the same setting, I think there's a lot of questions about that, and we need more data to really convince ourselves that that's the right thing to do, particularly if the transplant is for cirrhosis as opposed to hepatocellular carcinoma with preserved liver function. Now let's think about getting weight loss done, and I'm going to spend the rest of my talk now talking about that. The body seeks a stable adipose tissue mass. That is a characteristic of the body. Not all tissues in the body are set to this kind of a mass set point, but certainly some are. Liver is, red blood cell mass is the targeted regulatory outcome for when we give transfusion, when we give blood for transfusion, for example. So whatever is causing obesity is missetting the defended fat mass. And if we really want to get the weight down and keep it off, we have to lower that defended fat mass. And that defended fat mass, I'm not going to go through it on this slide, but there are a lot of feedback loops about how much fat mass we have, which is the fat is signaling through leptin and other adipocytokines, how much energy we need from the peripheral tissues that utilize a lot of energy. Brain is not listed here, but brain, muscle, liver, bone, fat itself. And of course, the GI tract, which is signaling what's coming in terms of not only calories, but the regulatory function of those calories. And we eat about 5,000 nutrients every day if we have a complex diet, and we know of 200 different distinct receptors in the gut for these different nutrients. We know that we can separate out, the brain can separate out fructose from sucrose, can separate out short chain, medium chain, long chain, saturated, trans fatty acids. Now, if you put somebody on a very low-calorie diet, as was done by Joe Prieto and colleagues in Australia in this New England Journal paper in 2011, I'm showing this paper, I normally show this slide to set up the idea that why people will regain the weight, but this slide shows it. If you put people on a very low-calorie diet, they will lose a lot of weight over this, in this case, 8 weeks. And then on a maintenance diet, you can see that over the next year, the patients regain about half the lost weight. And what these investigators did was they showed that that was due to changes in physiology, that those changes in physiology are pushing the patient back up to the original defended fat mass, which is why these diets fail over the long term. So if you're thinking about a calorie-restricted diet, like a very low-calorie diet or a low-calorie diet, you're talking about short-term weight loss, which may be exactly what you want pre-transplant, but you have to make that decision. Now, if you make the decision that you're trying to prevent the recurrence of NASH, short-term isn't going to do the job. And if you're trying to prevent the progression of NASH, if you catch somebody much earlier, long before transplantation, then short-term is not going to be helpful. So if you think about body fat mass set point, there are a number of things in our current environment: abnormal diet, unhealthy muscle from no exercise, sleep deprivation, stress, disrupted circadian rhythms, and drugs, all of which, by the way, happen to be drugs that are used to treat the complications of obesity. And with these influence over a long period of time, you see that this set point for body fat mass, defended fat mass, goes up. And if you want to treat obesity effectively, particularly over the long term, you've got to push it back down. So we use lifestyle modification, but these arrows, these green arrows, are relatively weak because with years and years of exposure to the upward pointing arrows, think what happens when you put somebody on corticosteroids for a decade. When you take away the corticosteroids, the weight does not come off because of the years of adaptation. Same thing is true with stress, eating, disruption of circadian rhythms in third shift workers and the like. When that doesn't work, we go to medications, and when that doesn't work, we go to bariatric surgery. This is just routine treatment of obesity. So our stepwise approach, there are all kinds of algorithms out there that I challenge the people who write the algorithms to reproduce them. We have a very simple algorithm because I can remember it. 1, self-directed lifestyle change, all of those 6 things that I just talked about. 2, when that doesn't work, we bring in professionals, professionally directed lifestyle change. Same lifestyle change, but it costs money now, a lot more money. But they provide support, motivation, reinforcement, et cetera. When that doesn't work, we invariably go to drugs. I'll show you that in a second, because I think drugs is where you're going to end up over the next several years in your pre-transplant patients. And in a very small subset of patients who are sick enough or complex enough to get above this blue dotted line here, we use weight loss surgery. And when that doesn't work, we use combinations of therapies after weight loss surgery. Now, we have a lot of different therapies. Most people don't realize we have 45 or more therapies for the treatment of obesity. Some of them are lifestyle, different kinds of lifestyle. There's a paper that came out only 6 weeks ago that shows that an allele, a single nucleotide polymorphism in the FGF21 gene is associated with response to a low-fat diet. Even though people talk about a low-carb diet, people with that allele respond to a low-fat diet better than a low-carb diet, and people with the other allele respond to a low-carb diet better than a low-fat diet, suggesting that there's going to be a lot of complexity. You see a lot of diets here. The reason they're all listed is because different people will respond differently. Pharmacological therapies, devices, endoscopic, and surgical. So our core principles, if you're going to get a patient to lose weight before transplantation or even as part of the journey through fatty liver disease, is 1, to reduce the elevated fat mass set point. 2, recognize the enormous heterogeneity, I'll show you that in a second, in both the causes and manifestations of obesity. 3, recognize that these variability of the obesities, plural, more than 100 different types, leads to wide patient-to-patient variability. Imagine trying to treat all cancers with your favorite anti-cancer therapy, all cancers. well, the heterogeneity of cancers would not allow them to work. So here's an example. This is a diet, a drug, a device. This is the endobarrier device and gastric bypass. And you see that the shapes of the curves and the width of the curves are similar across all modalities. It's where the mean, the median, and where they cross zero, or how many cross zero. So you see with a diet and liraglutide, which is also called Victoza or Saxenda, some patients in these controlled trials gained weight on the drug or on the diet. In the case of the device or surgery, nobody gained weight in these studies. But you can see that even with surgery, the standard deviation, the width of this curve is the same. And so you've got enormous patient-to-patient variability. So the other two core principles of obesity treatment are, one, people who respond to one therapy may or may not respond to another therapy. People who fail to respond to therapy 1, 2, and 3 may well respond to therapy 4. That's exactly the process that we all go through, which takes us a long time, so we have to accelerate that for NASH patients. So the strategy is to match the patient with the best therapy, which means in response to what I was challenged to do, which is what's the BMI target, we never have a BMI target, because all our target with our patients is the maximum weight loss that can be achieved safely. And frankly, we have no choice over that, and neither does the patient. So we look at every kind of therapy. There's this heterogeneity of response. We're always looking for the target group, the people who might get bariatric levels of weight loss with a diet or with a drug. It doesn't happen often, but in some drugs it happens in 10 to 15%. And if you start to add it up, before I worked in this field, I worked in hepatitis C 25 years ago when the sustained viral response rate was 4 to 5%. I need not say what it is today, and the fact that we can only today do 15 to 20 for 15 to 20, which means we can get 15 to 20% weight loss in 15 to 20% of patients. That's a heck of a lot better than we could do a decade ago, and hopefully we'll follow the hepatitis C pathway hereafter. So again, coming to our stepwise approach, lifestyle change, it's very simple. We look at these 6 different things. They're pretty easy to remember. And we simply go after each one of those things. We use checklists with the patients. We take a history that way. If a patient is exercising, there's no point in adding exercise. If the patient is eating a healthy diet, look elsewhere. If the patient's a third shift worker, go after it. Then if that doesn't work, we go to pharmacotherapy. And for pharmacotherapy, we've got 6 approved drugs listed here: phentermine, the combination with topiramate, Contrave, which is bupropion and naltrexone, lorcaserin, liraglutide, and orlistat. But in these drug categories, there are other drugs that have not yet been approved for the treatment of obesity. And so we have a bunch of other drugs, like with liraglutide, on the 5th one down, you can see we have exenatide and dulaglutide. There'll be other ones coming that are even better. With canagliflozin, which is an SGLT2 inhibitor, you can see we have 3 of them now. Empagliflozin, probably the most successful of them. But all of these drugs can cause weight loss, and they are all safe to use. But I'll talk about that as I finish up. So our strategy for using anti-obesity medication is, one, we want to wait for stability. The reason we want to wait for stability is we want to have the most sensitive assay as to whether that particular drug is working for the particular patient. If the patient's gaining weight and stops, how do you know it was the drug? If the patient's losing weight and continues to, how do you know it was the drug? And I'm going to use these drugs for the rest of the patient's life if I need to. Choose a medication or a combination of medications. We have guidelines for that. Institute what we've named a safe use protocol, because everybody thinks that these drugs are unsafe. They're not unsafe. It's just that people don't like to treat obesity. Start the medication, use an introductory dose, escalate as needed, evaluate for safety and effectiveness at 1 and 3 months. 1 month so that if it doesn't do anything, you move on. 3 months to see how well it did, and then keep going. So, what's our implementation strategy? Patient's stable, we give them treatment number 1. They lose some weight, we wait till they're stable, we give them treatment number 2, they don't lose any weight, we get rid of treatment number 2, we give treatment number 3, which is really their second effective treatment, they lose some more weight, we wait, and that's the end of that story. Now this process here took about 16 months. If you've got somebody who needs to go to liver transplantation soon, you're going to have to speed it up. And we don't really have good protocols for speeding it up, but we know that we're going to have to figure out how to do that. So in conclusion, we need to differentiate the need for short and long-term weight loss. Short-term weight loss, if we want to get through the acute risks of transplantation surgery. Long-term weight loss, if we want to prevent recurrence, or if we want to treat the NASH in the first place, or prevent its progression. For short-term or urgent weight loss, calorie restriction, either low-calorie or very low-calorie diets are going to be most effective. but they don't extend into weight maintenance, so therefore they're not good for the long term. For long-term weight loss, changing the physiology is required. And for urgent long-term weight loss, as occurs in this population of patients, we want to optimize the lifestyle and weight-influencing medications. So we really want to look at those 6 lifestyle contributors so that we can move through that list quickly and figure out what's right for that patient. Escalate rapidly to anti-obesity medications based on these safe use protocols that I described. Reserve bariatric surgery for the treatment of NAFLD at any stage, not as immediately before transplantation until better data come in. Thank you very much.